Hi, this is Suno Yoon from Seoul National University Hospital. Today, I am going to talk about the epidemiology of COVID-19, clinical characteristics, CT findings, changes of the CT findings over time, whether or not chest CT scan can be used as a screening or diagnostic tool, X-ray findings, and finally, the role we expect CT to have. The first topic is an epidemiology of COVID-19 outbreak. The Chinese CDC reported the summary of about 17,000 patients with COVID-19 in February. Among the patients with COVID-19, 62% were diagnosed with PCR assay and symptoms, and the remaining 37% were either suspected or clinically diagnosed cases without PCR assay. PCR assay was not available in all cases. We can take into account the characteristics of early outbreak of the COVID-19 that spread very promptly. 1% of these patients did not have symptoms, but PCR assay was positive. The largest age group was between 30 and 79 years of age. The next was 20s and then 80s. With regard to a disease severity, 81% was mild, 14% was severe, and 5% was the critical group of patients. The case fatality rate in COVID-19 was about 2%. The problem is that in critical cases, half of the patients died and the death rate increased dramatically as people got older, especially age of 70 or above. Another problem is with medical institutions. Most healthcare personnel have been impacted in the city of Wuhan, and 5 members of the medical staff have passed away as of February 11th. Here is a table from the Journal of JAMA. The text in the middle indicates the date, and the text on the left is the number of cases. Based on the dates of symptom onset and diagnosis, you can see a sharply increasing the curve. Let's take a closer look at how the disease was first discovered. The disease was first discovered on December 26th. There were cases before the date, but this was retrospectively identified by the Chinese CDC. Dr. Li Wenliang was famous in the media, but the first person to have actually discovered the disease was Dr. Jinxiang Zhang. On December 26th, at a hospital, a couple was suspected of having viral pneumonia, and their son had no symptoms, but CT showed similar findings. And one seafood market merchant also showed similar findings. Dr. Zhang reported this to the hospital, then similar patient continued to be seen. I searched the hospital where Dr. Zhang was affiliated on the Google map. The hospital is 9 minutes apart from Huanan Seafood Market by car. Unknown pneumonia became a social issue when Dr. Li Wenliang posted it on WeChat on December 29th. The coronavirus was identified on January 7th, and the sequences were shared rather quickly. The Huanan Seafood Market was closed on January 1st, and the city of Wuhan was closed on January 23rd. Dr. Li Wenyang went to heaven on February 7th, and Dr. Zhang, who made her first report, received an award on the same day, ironically. This is the first report of COVID-19 in the NEJM. On the left is an electron microscope of the coronavirus. If you look at the pictures on the right, you can see that the coronaviruses are placed between a respiratory cilia, forming either extracellular or intracellular inclusion bodies. And this is the chest radiograph of the husband of the couple who was first discovered. Unfortunately, he passed away. This virus has been named as SARS coronavirus 2. Upon sequencing, the shape of the receptor was found to be similar to that of the SARS coronavirus, so it was named SARS coronavirus 2. To respond to this outbreak that spread very quickly, reports have been made to the WHO on December 31, one day before the Huanan seafood market was closed. A global wallet was released within a month. Compared to the experience of SARS in early 2000s, you can see that WHO and Chinese CDC reacted much more in a timely manner since the first patient was found. Comparing COVID-19 to SARS and MERS, SARS, MERS, and COVID-19 have a all zoonotic transmission. The symptoms are similar too. They commonly present fever, cough, and frequently have a lower respiratory disease. The prognosis was poor in the elderly and those with comorbidities. The diseases are diagnosed with RT-PCR assay, but there is no special treatment yet. The difference is that both SARS and MERS had high mortality rates. The mortality rates in COVID-19 may be lower than that in SARS and MERS, but COVID-19 impacted a great number of patients. Ultimately, COVID-19 is causing far more death worldwide. Another difference is that the most secondary transmissions of SARS and MERS occurred in hospital. However, for COVID-19, we are probably going through a global emergency as now, since community infections are prevalent. As of April 15, 1,900,000 people are confirmed as infected by COVID-19, resulting in the mortality of about 100,000 cases. In summary, COVID-19 typically occurs in middle to older aged people. About 1/5 of patients with COVID-19 suffer from severe illness, and the mortality rate increases for the elderly and those with underlying diseases. Despite the rapid response, the outbreak is expanding globally. Next, I will cover the clinical characteristics of COVID-19 patients. The main mode of COVID-19 transmission is through a respiratory droplet and contact transmission. The US CDC recommends keeping at least 2 meters apart, yet in China, cases have been reported for transmission from up to 4.5 meters. Airborne transmission may be possible in the context where aerosols are generated, such as endotracheal intubation or bronchoscopy. When infected with COVID-19, it usually takes about 5 days to develop symptoms. If you look at the data from the early outbreak of China, there were only half of the patients who had fever when they were admitted to the hospital. However, more patients got fever while they were in the hospital. Other common symptoms include cough, fatigue, sputum, and short of breath, or in that order. Blood test shows lymphocytopenia in most patients. COVID-19 can be accompanied by several other abnormalities, especially by a significant increase in the C-reactive protein. 59% and 85% of the patients with COVID-19 had abnormal findings on chest radiographs and CT images. What's particularly noteworthy is that about a quarter of the patients in severe or complicated pneumonia had normal chest radiographs. Based on clinical ATS criteria and the composite outcome, 15% and 5% of the patients suffer from severe pneumonia. Patients who suffer from this severe pneumonia tend to have a history of chronic smoking, a short of breath, comorbidities, bilateral involvement on radiologic examinations, laboratory abnormalities, or are elderly. Patients with severe or complicated pneumonia had higher rates of intubation, ICU admission, or death. But those who do not have these risk factors have relatively good prognosis. In summary, half of the patients with COVID-19 may not have fever at admission. Upon X-ray imaging, up to 40% are normal. Prognosis is not good for people with risk factors. Now, let's look into the CT findings of COVID-19 pneumonia. In COVID-19 pneumonia, ground glass opacity is the main CT finding and accompanied by some consolidation. Pure consolidation is rare. CT abnormalities often show multiple lesions and bilateral involvement, usually in the peripheral and posterior lungs. Craze paving appearance and air bronchogram can be accompanied. And one interesting finding is that although the frequency is lower, reversed halo and fluid effusion can be seen. These are representative figures nicely illustrating typical CT findings of COVID-19. Ground glass opacities are predominantly distributed along the peripheral posterior lungs. And some regions include consolidation that are accompanied by air bronchogram or craze paving appearance. In other regions, nodular ground glass opacities are seen along the bronchovascular bundles. COVID-19 may manifest as a reversed halo sign on chest CT images, although they may resemble the reversed halo in organizing pneumonia. Some halos appear to have thicker limbs, and some parts of inner attenuation are higher than pure ground glass opacities. One case with COVID-19 manifested as a single nodular CT halo sign in the literature. In summary, typical CT findings of COVID-19 are pure to mixed ground glass opacities with a patch to confluent or nodular shape in the bilateral peripheral posterior lungs. And fluid effusion, lymphadenopathy, cavitation, or small nodules are rarely observed. Then, how COVID-19 pneumonia can change over time? This figure shows the frequency of particular CT findings according to the disease time course. In the early stage until the second day, about half of the patients showed normal CT findings. However, as disease progressed, these ground glass dominant lesions changed to the typical CT findings, such as increased consolidations, bilateral disease, and peripheral distribution. When the CT findings was assessed using a visual CT score, a peak was shown about 10 days from the symptom onset, and after about 2 weeks, the lesions gradually decreased. The representative CT images illustrate a typical temporal evolution of COVID-19 pneumonia. On the third day after symptom onset, COVID-19 initially manifests as a patch of ground glass opacities with some consolidation in subfloor areas on the right lower lobe. On the 7th day, the lesion extent increased, and the 11th day, some of these lesions disappeared and the new lesion appeared. On the 20th day, the lesions are nearly resolved. In summary, at the early stage of symptom onset, pneumonia may not be as seen on CT scans up to half of the COVID-19 patients. The ground glass opacities dominate CT findings, and there may be less typical findings of bilateral or peripheral distribution. Pneumonia has the increasing density and extent until a week of symptom onset, and after more than a week, a peak occurs around 10 day, and the pneumonia slowly decreases, but the rate of decline varies substantially. Next, let me deal with a diagnostic accuracy of RT-PCR and CT in COVID-19. Recent studies have suggested that chest CT scans could be used as a primary screening or diagnostic method for COVID-19 in epidemic areas. We are very curious about this, and I properly conducted a meta-analysis. For chest CT scan, the pooled sensitivity and specificity were 94% and 37% respectively. The pooled sensitivity of RT-PCR was 89%. Substantial heterogeneity existed on the pooled estimates for chest CT and RT-PCR. And chest CT had a higher sensitivity in studies with a higher proportion of severe disease, comorbidities, and lower proportion of asymptomatic patients. RT-PCR had a higher sensitivity in studies with a lower proportion of elderly. These two figures show estimated positive and negative predictive values of chest CT scan and RT-PCR. The bottom bar indicates disease prevalence, and the left bar denotes predictive values. Given the low specificity of chest CT scan, there is a large gap in the positive predictive value between chest CT and RT-PCR in lower prevalence regions. This table shows estimated predictive values of chest CT scan and RT-PCR for COVID-19 in 9 countries based on their actual disease prevalence. The prevalence was defined as the proportion of the patient diagnosed with COVID-19 among those tested with RT-PCR. In low prevalence countries, the positive predictive values of RT-PCR was more than 10 times higher that of CT scans. The negative predictive value of both methods ranges from 90% to 90.9%. In summary, a chest CT scan for primary screening or diagnosis of COVID-19 would not be beneficial in a low prevalence region due to the substantial rate of false positivity on chest CT scan. Next topic will cover chest radiographic findings of COVID-19. Common chest radiographic findings of COVID-19 resemble the typical CT findings: bilateral, peripheral, consolidations, and or ground glass opacities. Baseline chest radiographs had a sensitivity of 25% to 69% and a specificity of 90%. Chest radiographic abnormality preceded a positive result of RT-PCR assay in 90% of patients. We can calculate what percentage of the lesion identified on chest X-ray images if COVID-19 pneumonia are seen with X-ray imaging. In this patient, COVID-19 pneumonia involves about 20% of lung parenchyma in on CT images. In anterior-posterior projection laid-on view, we can find about 60% to be involved, but only about half are found through X-ray images. Even if identifiable, approximately half of the pneumonia cannot be seen on chest X-ray imaging. In summary, a considerable portion of patients with COVID-19 pneumonia had normal chest radiographs. Chest radiographs had a high specificity, but a low to medium sensitivity, and even if identifiable, only half were seen on chest radiographs. We should place a different values on chest CT imaging rather than with diagnosis. Finally, we will look at what we can expect from a chest CT imaging. This is a situation we simulated for taking a chest CT scan for COVID-19 patients. In our hospital, we use a negative pressure chamber to take CT scan, and it is very laborious. After CT scanning, the area should be disinfected. However, it can definitely be worse in particular patients. Identifying patients with poor prognosis of SARS, MERS, and COVID-19 is very important in determining how to efficiently distribute the limited medical resources. Indications for poor prognosis include a bilateral disease in SARS, and also a bilateral disease, a greater involvement of lung parenchyma or fluid effusion in MERS. And recent papers have reported that COVID-19 patients had poor prognosis if there was enlarged lymph node, fluid effusion, fibrosis, or a greater extent of disease. If we can triage patients who may get worse in advance, it would be very helpful. Indeed, according to the consensus statement of Fleishner Society, imaging is indicated for patients with moderate to severe features of COVID-19 regardless of COVID-19 test results, and for patients with COVID-19 and worsening of respiratory status. If we perform CT scan in COVID-19 patients, it is hard to visually quantify disease burden after CT scanning. Thus, we developed free AI software for the automatic quantification of COVID-19 pneumonia on CT images and distributed worldwide in March 18. MediCOVID contains the 2D unit as downloadable free software for local use on computers without data privacy concerns. MediCOVID-19 automatically calculates the extent and weight of COVID-19 pneumonia, and in the internal validation dataset, the intra-class correlation coefficients between the 2D unit and reference values for extent and weight of pneumonia were around 0.99, and the correlation coefficient were maintained in the Japanese and Italian external validation dataset. In summary, a CT will probably play a crucial role in triaging patients with severe disease and predicting prognosis. To achieve this, we freely distributed an easily implementable automatic CT quantification tool for COVID-19 pneumonia while collecting a large number of patients. We can expect radiology to play an important role in managing COVID-19 pneumonia. These are today's topics that I covered, and this brings me to the end of my presentation. Please stay safe, and thank you. Actually, I have never encountered a patient with COVID-19 who had pulmonary embolism. For the immediate workup in COVID-19, non-contrast chest CT scan is generally recommended as a contrast enhancement in the lung parenchyma may mask the presence of a subtle GGO in COVID-19. Nevertheless, COVID-19 patient in a certain portion of COVID-19 patient can have a laboratory abnormality that is elevated D-dimer. And in such cases, a contrast enhanced chest CT scan would be helpful to exclude the possibility of pulmonary embolism in those patients. Imaging modalities for workup of COVID-19 patients depends on human and facility resources, availability of a disinfection, and disease severity of the patients. In the setting without a significant constraint of resources, chest CT can be used for the patient with moderate to severe pneumonia to assess a disease burden, a pneumonia burden, and other potential complications of pneumonia. And if there is any clinical evidence or clinical suspicion on a disease progression, chest radiographic imaging can be introduced for the to assess those patients. And but if there is a significant resource restrictions, chest radiograph may be introduced for the imaging workup of those patients. And although chest ultrasound may be used for the imaging workup of COVID-19 patient, the current publications are mainly handles a preliminary observation observation on the use of a ultrasonography in COVID-19 patients. So I think the chest ultrasound may need some time to be implemented in the clinical practice of for imaging workup of COVID-19 patient. And if you want further information, please refer to the recent publication of the Florida Society in Radiology and Chest Journal. Thank you.